My patient X, age 65-year, female lady, residence of Dianapur, shopkeeper by occupation, presenting with a chief complaint of ulcer over the left lateral border of tongue for 4 months. Patient was apparently all right 4 months back. Then she insidious noticed one small ulcer in the left lateral border of the tongue, which was initially small in size and then rapidly progressing to the present size around 4 into 4 centimeter. And ulcer was associated with the pain, which was radiating to the ear. And the pain was intermittent in onset and relieved by some medication, but after medication, effect of medication, pain continues along with the radiating to the ear, and no history of any excessive salivation and foul discharge, no history of bleeding from the ulcer, no history of any loosening of tooth, no history of decrease in mouth opening, and there is no difficulty in there was difficulty in chewing and chewing the food because patient was edentulous, and but there was no difficulty in swallowing. There is no hoarseness of voice, and there was no history of any ill-fitting denture, and there was no history of any lesion in the lesion in the oral cavity or neck, and there was no history of hemoptysis, chest pain, and breathlessness, and no history of any tobacco consumption, and no history of alcohol intake in the past. Then she presented to us, and after that patient underwent biopsy and imaging. Imaging he was not able to describe under which investigation she has been done. She was married with 3 children and no history of any surgical illness in the past. She is known case of diabetic and hypertensive since 10 years and on medication, well controlled. So I would like to summarize my history that 65-year edentulous lady presented to us a small ulcer presented to us with a small ulcer which rapidly progresses to the present size on the left lateral border of the tongue, which is painful and radiating to ear. So this rapidly progression, the most probable diagnosis is CA tongue.
Would you like to give any differential diagnosis?
For old lady, ma'am, and not associated with any type of and 4 months history. So non-healing ulcer since 4 months. My most probable diagnosis is CA tongue only. It can be due to some inflammatory reasons, that is very rare, caused by granulomatous infection, but it's very rare.
Okay. Can you enumerate a few painful and painless ulcers?
Chronic traumatic ulcer is a painless ulcer, but aphthous ulcer and that granulomatous ulcer is also painless ulcer. But aphthous ulcer is a painful ulcer, and
okay. I mean, these ulcers can change their characteristics over a period of time. Means painful can become painless, painless can become painful. Okay. So go back to your history once. So, right. So you can actually mention, means not all examiners will agree about peanut and all, but you can actually mention the size, okay, approximately of this size, You can tell like that. Like started as 1 cross 1 centimeters, has grown to present size of 3 cross 2 centimeters. Okay, it's accepted. Some will accept saying left lateral border of the tongue, but some may say it's left side of the tongue. Okay, so that is one thing. So what is the cause of uh, pain radiating to ear? What is the pathway?
So since the ulcer is in the anterior and the anterior part of the tongue, so most afferent is lingual nerve, and along with its relay pathway on the efferent pathway is the auriculotemporal nerve, which radiating pain to the ear. If same ulcer in the posterior part of the tongue, then via glossopharyngeal nerve and Jacobson nerve, it will radiate to the ear.
So which part of the ear? So I'll tell you where the ulcer is expected if it is radiating to the pinna, where is the ulcer if it is radiating to the middle ear, and where is the lesion when it is radiating to the inner ear, or where is the lesion if it is radiating to behind the ear.
Auriculotemporal nerve, ma'am, behind the ear. I'm not sure about.
So generally, if it is lesions in the tongue, okay, anterior 1/3 of the tongue, anterior 2/3 of the tongue, then it will radiate to the pinna and external ear. Okay, when it is in the lesions in the glottic region, okay, so it will radiate to the inner ear. Okay, and the posterior third, as you told, glossopharyngeal, that might be going to the middle ear. So this is the pattern. And what about what is the reason for excessive salivation?
Due to chronic irritation of the ulcer, due to saliva and food, it's got excessive salivation.
Yeah. Can you tell me what are the types of the pain that can be present in oral cavity? One you talked about neuropathic pain, means referred pains. Okay.
One burning sensation due to mucosal irritation.
So one is irritation. Okay. One is neuropathic. Then anything to advance lesions that might be present?
Advanced lesion.
So they might lead to nerve involvement, infiltration. Okay. Yeah. One is referred pain, one is per se due to infiltration, and one is because of the irritation and secondary bacterial infection leading to inflammation. Okay.
Okay, ma'am.
So why is there difficulty in speaking? In the anterior 2/3 of the tongue, for the lesion approximately to present size means how big is it?
Around 3 into 4 centimeter.
3 into 4 centimeters. So, do you expect 3 cross 4 centimeters lesion confined to anterior 2/3 of the tongue to cause difficulty in swallowing?
If it is reaching the base of tongue, then vision can have difficulty in swallowing.
Yeah. If it is in the posterior third of the tongue, it can have, or base tongue, then it can have difficulty in swallowing. If it is confined to the lateral border of the tongue and anterior 2/3, it will not have. Okay. So why is there difficulty in speaking? What do you expect? What is the pathology behind difficulty in speaking?
Because our tip of the tongue touching the hard palate while the speaking. So when there is the lesion in the floor of mouth and the ankylosglossia, the mobility of the tongue is restricted. At that time, patient can have difficulty in speaking.
Mm-hmm. Right. Where is there difficulty in chewing in a tongue lesion?
Chewing, ma'am, middle of part or dorsum aspect of the tongue because that is for swallow.
There is difference between oral cavity symptoms you should ask and tongue symptoms. Okay. So tongue, what matters is, first thing is there is any increased salivation. Okay.
Yes.
So there is any referred pain to ear. Okay, which will tell you whether it is early or advanced. When there is referred pain to ear, when patient comes holding his ear, that means already it's an advanced lesion. It tells you it is an advanced lesion. Okay, so just by seeing patient, you can tell. Okay, that it is an advanced lesion. So difficulty in speaking is not relevant here. Okay, there is rather than loosening of teeth, you should have told something else. What can you tell?
Loosening of teeth for this patient, it's worthless because patient.
It is not. No. For tongue lesion, why is there loosening of teeth?
If it is floor of mouth extending and leading the mandible region, then it's significant.
It is very unlikely, no, for a tongue, means unless it's very advanced. So first symptoms first. So you should ask any history of sharp teeth, injury due to sharp teeth. Okay, that is more relevant. Okay. Any history of injury due to sharp teeth, any history of caries tooth. Caries tooth will tell you some habits and all. So they are more relevant than loosening of teeth. Loosening of teeth is more for alveolar lesions. Okay, or buccal mucosal, gingivobuccal sulcus lesions. Okay. Yes. Why did you ask hoarseness of voice?
To rule out second primary like oropharynx or larynx.
Okay, but you should keep it down the see what when patient says you symptoms, okay, you put it in an order so that first they should point towards your diagnosis and they should get the idea of what you're telling and stage. Okay, so some hoarseness of voice and all, okay, second primary field cancerization, all this will come, but like you're telling metastatic symptoms. Okay, so they're very unlikely to involve pause loosening of teeth or a hoarseness of voice in a tongue lesion, anterior 2/3. Okay.
Okay.
So just arrange it. Okay, and some questions are not to be asked for tongue. When it is a tongue case, it is tongue case. Like some questions are to be asked for oral cavity. Okay, so next, any masses in neck you told for secondary. Okay, fine. Then how does tobacco cause cancer?
Tobacco itself is like addictive product, but nicotine is an addictive product, and tobacco itself has nitrosamines and it forms DNA adducts, and it decreases the cytochrome P450. So it induces the carcinogenesis, and it's also help in. It's also promote the P53 loss also. So tobacco itself, due to nitrosamines and NNK and NNN, it's behave like a carcinogen.
Okay. So whenever you are asked how tobacco causes cancer, you can put it in. You have told everything, but you put it in a proper way. Okay. So there are three mechanisms by which tobacco can cause cancer. Okay. One is local irritation. Okay. Local irritation, and second is due to genetic causes, whatever P53, P21, that whatever pathways are affected, cytochromes and all, that comes in all the genetics, DNA adducts formation and all. Okay. Local irritation, inflammation, and then inflammation causing release of carcinogens, and then genetic causes. So if you divide it into this, you'll never forget. Okay. So, okay, what will you ask when patient says, I have consumed tobacco? So what all you want to ask?
Gutka, khani, areca nut, betel nut. In what form tobacco taking, or either smokeless or
So first of all, you'll ask whether it is smoking or chewing, right?
Yes.
So what has got relevance in oral cavity cancers? Is it more of chewing or more of...
Smokeless tobacco has more significant than smoked tobacco, that is BD and cigarette.
What are forms of smokeless tobacco?
Khani, gutka, and betel quid.
So partially you should know everything about tobacco. Okay, whatever is in Devita, you should know everything. Okay, it depends on place you get it as center. Okay, what they consume. So somebody will tell I take that powder and apply it as paste. Okay, in the Maharashtra side and all they do that. Okay, and some say Mava, some if you get in Northeast, it depends on your center. So please see before going so that what is the most common form of tobacco that is consumed there. Okay, so so what will you ask? Okay, you will ask smoke. It is a tobacco chewing or it is smoking, right? Next, what will you ask? Suppose chewing. What all you want to ask?
How many times a day, or how many years you have taken the product, and along with any substance, or you take with alcohol or not.
Okay, so whenever you are asked about chewing tobacco, okay, so you ask what is the contact period time. Okay, so you told no how many times a day. So times also is important. Each time when he takes it and spits it after 20 minutes, spits it after 1 hour. So there makes a difference, right? So it is contact period. Okay, so and what form he takes. Okay, how many years he's been taking. As you told, if it is consumed with alcohol or not. We'll come to alcohol. Okay. If it is smoking, what you'll ask?
How in the what form, BD or cigarette, or how many pack he's taking in a day, for how many years he has taken.
Okay, what is pack years?
Number of packets he has taken for how many years.
Number of packs into number of years. Okay. So how many cigarettes are there in one pack?
12, I guess.
Is it 12 or 20?
It's 10 in Indian scenario and 20 in
10. In abroad it is 20. Okay. So what about BD?
बीड़ी बंडल में आता है. But BD is more dangerous than cigarettes, because BD's cigarette has filter and BD doesn't have filter, and its leaf is also a type of carcinogen.
Okay, that's all fine. How many BDs are there in one packet?
That I don't know.
If I'm not mistaken, I think it's 24. Just check it out. Okay. So, okay. Now, since you have talked about leaf, tell me what all they can put in tobacco chewing. Okay. Suppose it is pan, masala, or gutka. So, what all are the things?
Slake lime, areca nut.
So, betel leaf, correct? On betel leaf, what they'll use?
Jarda.
betel leaf में चूना लगाते हैं ना, तो क्या है चूना?
Slake lime ना.
Yeah. Next, what they put?
Supari.
Okay, supari or areca nut. Most of them use. Okay. And some will put this tobacco powder. Okay. So now you tell me importance of each. beetle leaf, beetle nut. Carcinogenic, not carcinogenic.
Areca nut is carcinogenic. Betel leaf also have some alkaloids which are carcinogenic.
Areca nut has what carcinogen?
Ericoline and
Ericoline mainly.
ericoline, alkaloids and phenols.
So alkaloids and
Phenols.
Flavonoids.
okay. And what is there in what is the use of flaked lime? I mean, not use. What is the pathology with flaked lime? What it does?
Submucous fibrosis is a main. It's a main risk factor for submucous fibrosis. It can cause cancer also, but its main role in
Flaked lime itself is irritant. Okay, so it causes local irritation.
okay.
1 second, now 1 second. Just hold on. Okay, can you hear me?
Yes, ma'am.
Yeah. So slake lime itself is irritate. Okay. So areca nut contains ericoline. Okay. Tobacco, as you told. Okay. What is the carcinogen when it is causing lung cancer, and what is the carcinogen when it is causing oral cavity cancer?
NNK is causing oral cavity and triple N causing lung cancer.
No.
Ulta.
PAH and benzene cause. Okay. They are smoked. They are more common in smokers. Okay. So these NNN and NNK, they are more common in chewing. Okay. Then
hydrocarbons and next. What next?
Yeah. So what are the contents which contain tannins? Have you heard of tannins?
Heard, but tannins is also present in tobacco only. But in which form of tobacco?
No, tannins, they stabilize these changes, whatever are caused. Okay, this is there in that areca nut and tobaccos. Okay, they basically will stabilize the changes that are caused due to secondary release of these carcinogens. Okay, tannins and alkaloids.
Okay.
Next, so what does alcohol cause? Is it an individual? I mean, it is carcinogen by itself, or it is co-carcinogen?
It is a carcinogen by itself also, and it's act as a co-carcinogen also. But when it acts as a co-carcinogen, it's a very synergistic effect. It effect increase to 4 times than the normal tobacco.
So it is called, when it is consumed with alcohol, it is called super multiplicative effect. Okay. So alcohol and tobacco will lead to super multiplicative effect. How does alcohol cause cancer?
Alcohol itself is a local irritant and it increases the solubility of tobacco products. Along with that, it local bacteria or that commensals can convert the alcohol into the acetaldehyde. Acetaldehyde itself is a uh, precursor for the cancer. The alcohol also form DNA adducts.
Okay. So alcohol will cause release of acetaldehyde. Where does it cause release of acetaldehyde?
Due to commensals, normally it does in the liver, but if poor hygiene of the oral cavity, then these oral cavity organisms convert alcohol to acetaldehyde in the oral cavity only.
Okay. So you all of you see the how much percentage of alcohol is present in whiskey, rum, all this wine. So all these things you should see. Okay.
Okay.
And what is the alcohol? cannot leave it saying he consumes alcohol or he doesn't consume alcohol. Examiner will be interested in asking, as they ask for tobacco, they'll ask for alcohol also. Okay. So you should know how much percentage of alcohol is there in each of the alcoholic beverages. Okay. So sharp tooth we discussed. Anything else? What are 5S in oral cavity etiology?
5 spices.
Yes. Did you tell that? So whenever in your history, you should include all 5S. Intolerance to intake of spicy diet, increased salivation, secondary to that. Okay. Next, second S is, see, some say you cannot tell it is spicy diet. Intolerance to intake of hot foods. So it depends on examiner. Most of them will accept when you say spicy also. Okay. There is some say there is nothing called spicy. You should tell hot foods. Okay. So, but it depends on examiner. Next. So, what is second?
Syphilis and high behavior STD.
Sorry.
High sexual behavior STD.
No. Something close to it. What is S? Which STD with S? Smoking, spirit, okay, sharp tooth, syphilis, and 5. Okay, all 5.
I'm not.
So why did you're getting disturbance?
Background, huh? Abhi okay.
It's not from my place here.
Now it's okay.
Okay. So smoking, spices, sharp tooth, okay, spirit, and syphilis. These are 5S. Okay. So what is problem with ill-fitting dentures?
Ill-fitting dentures can cause chronic irritation like this trauma patient. Trauma to the tongue or trauma to the...
So it's chronic irritation basically. That's it. Huh? So what you have asked about metastatic symptoms. So how common are the metastatic symptoms in oral cavity cancers? How much is the percentage?
Less than 15% of patients present.
15 is too much here. How many you have seen with lung mets here, oral cavity cancers?
Actually,
it's less than 5%. Okay.
5%.
Then okay. So most common site of metastasis other than locoregional lymph nodes. What is the distant metastasis that occurs in oral cavity cancers?
Lung.
Yeah, lung. So fine. Is there any family history significance in oral cavity cancer?
Yes, ma'am. In which the patient have DNA repair, like Bloom syndrome, Werner syndrome, Fanconi anemia, and
ataxia, telangiectasia.
In which NP53 itself is can be associated with the genetic syndromes. So these are the factors which can lead to oral cavity cancers or head and neck cancer.
Okay. So did you for anything next history? Okay. So why did you ask marital history? Any significance in oral cavity cancers?
No.
As a part of routine thing.
Of my history sake, personal history I have taken for the patient.
Okay. So you have forgotten something important. So whenever there is oral cavity case, any history of previous dental interventions, okay, rather than any surgical illness, it is dental interventions that is very important. Okay, if it is oropharynx, okay, then you can ask for HPV, that is in marriage, sexual, high risk sexual behavior and all those things. But in oral cavity, it's not there. Importance is not there. Okay. So what has diabetes mellitus and hypertension got to do with oral cavity cancers? Is there any relation or
Diabetes, ma'am, can lead to the high chances of infection in the post-op. It should be well controlled for any of the patient we are taking for operative purpose of treatment. It should be controlled.
Okay. So you want to plan for surgical intervention. So any immunosuppression also you should ask. Okay. Then I think more or less. Okay, fine. So if you now you are telling it's a most likely a malignant lesion, correct? So you think it's early lesion or an advanced lesion based on your history? Just based on your history.
Based on history, ma'am, it's the early lesion because.
And one more thing, I think, did you ask about history of fever or anything?
History of
Fever.
fever, I didn't ask.
Yeah, you should rule out inflammatory. As I told, okay, your history, duration, everything is fine. But to rule out the inflammatory condition, sometimes you should ask about fever. Okay. So, yeah, you tell me now. So, 4 months duration.
4 month duration. About 3
And pain radiating. So, it has doubled its size.
Yes, ma'am.
Okay. And one more important point is she is edentulous lady. Okay. So, and a non-healing ulcer. So, when do you call ulcer as non-healing?
More than 4 weeks, if ulcer is not healing in spite of all medications and precautions, then we say them non-healing ulcer.
Is it 4 or 6 weeks?
4
I think
4 weeks, ma'am.
4
And
weeks. Huh?
according to New Bailey, it's more than 3 weeks only.
Okay, fine. I remember reading it as 6 weeks. Maybe it changed. Okay, right. Okay. So you think is it early lesion or advanced lesion according to your history?
According to history, it's early lesion, ma'am.
You have said pain radiating to left ear.
That I will clarify according to after examination why it is so. Because
Okay, fine.
it is extending to ventral aspect more than the dorsum of the tongue, and it's quite nearer to the lingual nerve. So from starting only patient is having pain. So might be the site of origin not from lateral aspect, it's a ventral aspect of the tongue.
So you think it is not something due to referred pain?
It's due to referred pain due to irritation of lingual nerve, but lingual nerve on the ventral aspect of side, na ma'am, not in the main on the dorsum.
Okay. But if you are asked from your history, one thing that points towards ear pain is advanced. Okay. But I will confirm my this one with post examination. You can tell. Okay. Fine. Proceed examination.
I examined my patient in well-lit room with a proper informed verbal consent. My patient is conscious, cooperative, averagely built, well, and well-oriented to time-place person. Patient widely stable and epoch no pallor interest cyanosis and generalized clubbing and generalized pedinopathy. Local pedinopathy I will be addressing with my local examination. On local exam.
So in general examination, per se, if you are examining an oral cavity, what do you think is important? From what all you told, what is important?
That ma'am?
Yeah, performance status, the nourishment, okay, and anything else?
Pallor, because anemia. So
Yes, and lymphadenopathy, and chronic smokers will have clubbing. Okay, so this is important. So yeah, next.
So on inspection, patient is having adequate mouth opening with facial symmetry is maintained and normal mouth opening and no ankylosing. There is around 2 into 3 centimeter ulcer over the left lateral border of the tongue, single in size, 4 centimeter away from the tip of the tongue, 3 centimeter from the central valid papilla, and more on the ventral aspect of the tongue, and dorsally it is far away from the midline, but in ventral aspect of the tongue it is 1 centimeter away from the frenulum, and there is no other lesion in the tongue visible and no other neck or swelling can be is visible. Then patient is edentulous, and these all my inspective find ulcer-proliferative ulcer in the left lateral border of the tongue.
Anything else? You are only seeing the lesion. Anything else?
No.
What are oral potentially malignant disorders?
No other lesion in the oral cavity, I said. No neck.
Yeah, specifically you should say OPMDs, okay, in oral cavities. Okay. So no other lesions means no other sites of lesions. Okay. But OPMDs are very important. So tell me what are, first we'll go with pre-malignant lesions. So what are OPMDs?
There are orally potential malignant disorder is divided into low risk and intermediate and high risk, and discoid lupus erythematosus and lichen planus are the low risk OPMDs, where the erythroplakia, erythroleukoplakia, and these are the high risk lesions. Leukoplakia is intermediate risk factor as a OPMD.
So what is leukoplakia?
It is a diagnosis of exclusion. Any white patch of more than 0.5 mm which is not able to remove on the rubbing, then and excluding other all diagnosis is the we can say it's leukoplakia.
So there are definitions. Okay. So any whitish patch which cannot be clinically or pathologically characterized. Okay. So that is the definition. So what is leukoplakia means? What things you want to see to say that this leukoplakic patch is suspicious? It is not normal. So can you tell me in other words what are types of leukoplakia?
Leukoplakia can be homogeneous and non-homogeneous, and it can be correlated with the erythroplakia or speckled leukoplakia, nodular leukoplakia, and verrucous leukoplakia among non-homogeneous.
Okay. What is this size important? Where is the site important? Where you suspect?
Leukoplakia mainly in the gingivobuccal sulcus or GLS and GBS with the more act of carcinogen due to gravity, and patient used to keep gutka and khani near the GBS and GLS for the long time. So there are more chances of getting.
So what are high risk zones of leukoplakia? What are low risk zones? So okay, I'll give you a lead. Tell me in respect to buccal mucosa, tongue, hard palate, floor of mouth. So which are high risk zones in this?
Floor of mouth is also a high risk zone because pooling of saliva is there. And lower gingivobuccal sulcus is one of the Harris zone. Near anterior lip or mucosal.
So basically,
iris.
yeah, floor of mouth, okay, the posterior third of the tongue, these are high risk zones, okay. The palate and all are low risk zones, okay. And what is the relative risk of leukoplakia? How many times it has got risk, in other words?
Relative risk, I don't know, ma'am. Malignant transformation risk is 5 to 7% for leukoplakia. Relative
For
risk,
leukoplakia,
5 to 7% chance of malignant transformation in the lifetime, but relative risk I'm not aware, ma'am.
no, there is one numerical saying this much per year.
Okay.
It is 3.4% per year. Okay. And the transformation, it is 17 times. Okay. Whereas erythroplakia is 38 to 50 times.
Okay.
Okay. So, what is erythroplakia?
Red erythematous lesion over the buccal cavity. It's the
erythematous red velvety raised lesion, same, okay, which cannot be clinically or pathologically characterized. Okay, so now I'll give you some scenario. It is leukoplakia, erythroplakia, erythroleukoplakia. Which is more dangerous?
erythroleukoplakia.
Sure.
Because non-homogeneous है ना, तो it's more dangerous.
Is it erythroleukoplakia or pure erythroplakia which has got high risk? So erythroplakia has got about 50 times. Means if you see an erythroplakic patch, okay, so 50% times it is malignant. It has malignancy in it. Okay. So next comes erythroleukoplakia, next comes leukoplakia. Okay. What about chronic hyperplastic candidiasis?
Chronic hyperplastic candidiasis is also one of the moderate risk factors of.
Yeah. So anything else? You melanoplakia, is it risk factor or not?
In present, ma'am, I have not seen in the table melanoleukoplakia.
Yeah, it is. So melanoplakic patches are sometimes nutritional also. Okay, so it's not always like risk factor. Then what else? Yeah, so we discussed about this. Then okay. Then what will you start with? Lip. So lips are normal. Then comes OSMF. Yeah, we'll come to it in Christmas because lips will come to it in Christmas. So lips are normal. Okay. So what are parts of lips? Like in recent staging, what is the difference that has been changed, like previous compared to the previous PNM staging?
That, ma'am,
in regards to lip.
Extra oral vermilion border till mucosa. From mucosa, it's come into the oral cavity, and extra mucosal vermilion border is derived as skin cancer.
Correct. So okay, fine. So now you tell mouth opening. So what is mouth opening? What is normal mouth opening? What is the grading for mouth opening or trismus? Okay, what is trismus? And tell me something about OSMF.
Trismus is less than 35 mm if mouth opening, then then we are saying it's trismus, and divided into the grade More than 35 mm is normal, and 35 to 25 is grade 1. 25 to 15 is grade 2, and less than 15 is grade 3.
So from where to where you will measure this distance?
Inter-incisor distance to be measured.
Okay, fine. So tell me something about what.
Oral submucous fibrosis is collagen deposition in the mucosa, submucosa,
Submucosa.
submucosa, and also had different gradings, which can lead to form fibrous bands or can fracture.
So they are also graded, right? So do you have idea about any grades?
And 1, 2, 3, 4. That trismus is 4th and band is 3, and grade 2 and grade 1. One blanchable and non-blanchable, that I don't remember.
So one is that they have symptoms but nothing is visible. Okay. Then there will be some erythematous lesions. Okay. Then there will be formation of the bands, and then there will be finally leading to trismus. Okay. So और OSMF का कितना रिस्क है?
OSM. It's a very large range from 10 to 50% like this. Not.
If I remember, it is 8 to 12%. Okay, but
using with verrucous carcinoma.
No. I think whatever I remember, it is around 5 to 8% or 8 to 12%. I'm not very sure. So, but just see, it is not that much.
It is, I think 3 to 10, but Indian it is 20 to 30.
Yeah. What is the, why is it more common in India? What is the...
Because of this Erica net, madam.
Ericolit. So, that is more causing OSMF. Okay. Next, let's move to the alveolar, this one, teeth. So, what will you see in teeth?
Teeth staining, loosening of teeth, or any new dental intervention, because sometimes after intervention patient has sudden increase in the size of the lesion.
Okay. So you will see for nicotine staining of the teeth. You will see for any caries tooth. Okay. Loosening of teeth or lost teeth. So leaf and fall after the onset of the lesion, if there was any loss of teeth. Okay.
Okay.
And most important, in palpation, you will see, means even in inspection, sometimes it is evident, but more you can see on palpation, more evident on palpation is sharp tooth. Okay. So you have to feel for sharp tooth. Okay. And see, always make it a point to tell the dental formula. So any missing teeth. Okay. So here she is in edentulous, but in normal cases, I'm telling, you should always make it a point to say where the teeth are lost and when were they lost. That is important. Okay. So this we will discuss about the alveolar lesions and teeth, that modes of spread in buccal mucous, gingivobuccal sulcus and alveolar lesions. Now we'll go to tongue. Okay, we will divide at least oral cavity, per se oral cavity, into 4 parts. Okay, each time we will discuss new points, not which were not discussed in other class. Okay, so now I'm fitting that GBS area. Okay, the buccal mucosal thickness and all I'll fit, and next time I'll discuss the mandibular invasion and all. So now we'll come to tongue. Okay, so what are parts of tongue?
Tongue anterior and posterior anterior 2/3 and posterior 1/3 of the tongue, and the dorsum of the tongue, ventral aspect of the tongue, and lateral border. And it have two groups of muscles: intrinsic muscle and extrinsic muscle.
What are intrinsic muscles? What are extrinsic muscles?
Vertical and superior longitudinal, inferior longitudinal, and vertical and transverse are the group of intrinsic muscles. Palatoglossus, genioglossus, taloglossus. One more. Four are extrinsic muscles.
Hyoglossus.
Hyoglossus. Okay. So what are functions of this intrinsic and extrinsic muscles?
Intrinsic muscles may give muscular length of the muscle, and extrinsic muscles are attaching the tongue to the
No, Saumyta. See, each muscle has got one function. Okay. So this is very important in relation to your explanation and reconstruction later. Okay. So, what does palatoglossus do? What does hyoglossus do? What does styloglossus do? What does genioglossus do?
Genioglossus is protruding the tongue. Palatoglossus is depressing the end.
Palato, its name says.
Its palatoglossus is raising elevation the tongue and decreasing the oropharynx, so on the palate, so that oropharyngeal opening should be small.
So basically, it is elevation of tongue. Next, hyoglossus.
Hyoglossus depressing the tongue.
Depression. Okay. Next, styloglossus.
Styloglossus deviation and movement of the tongue.
No, right? Genioglossus is what?
Protruding.
Then styloglossus will be
inside करने वाला.
हाँ क्या है वो? Protrusion is next is retraction. Okay, so yeah, it will go behind. What about sideways movements? All are carried about the intrinsic. Okay, so then what are the nerves supplied?
Anteriorly, ma'am, chorda tympani for the taste sensations, and the lingual nerve as motor nerve. Sensorum.
Okay, and okay, you tell me only motor. Okay.
Hypo.
All the muscles except one are innervated by
hypoglossal.
So what is that muscle which is paired, and what are the innervated?
Palatoglossus is spared.
Palatoglossus. Okay. So what is the nerve?
Seventh nerve, ma'am. Seventh nerve, na?
Chorda tympani.
Chorda tympani is a branch of facial nerve only, and but lingual nerve is a branch of mandibular nerve. Sorry,
okay.
Read it.
So read it. Huh? So I won't tell, because if I tell everything, like you'll forget it. Read it. So read. Anatomy is very important, and in oral head and neck, they will ask anatomy. Okay. So what about yeah? So now you told already referred pathways and all. Okay, proceed to this one. We will see to it. Other points discussion.
On palpation, I have tenderness present, and inspection. I confirm my inspectory findings. The measurement around 3 into 3 into 1 centimeter. The degree of tongue indurated 3 centimeter from the tip, 4 centimeter from circumvallate papilla, 1 centimeter away from the midline in the ventral aspect, and in dorsal aspect around only confined to the lateral, that is more than 2 centimeter from the midline. Floor of mouth is free. Patient has no ankyloglossia edentulus and there is no palpable neck notes and jaw movements are normal. I would like to complete my examination with the Hopkins examination to rule out oro and hypopharyngeal to look for a second primary.
You are concerned about jaw movements or tongue movements?
Tongue movements also.
Tongue movements is common, not tongue. Okay. Tongue movements are more important here in this case.
मैम हॉपकिंस मेथड बोलना है उधर एग्जाम में हॉपकिंस मेथड
हॉपकिंस बोला उसने
नहीं बोला है
You have to tell whether sir I want to do Hopkins. If they don't provide, I would like to do a Hopkins examination, but I was not provided for the necessary things for the same. Okay, just tell I would like to do an Hopkins examination. Don't leave it.
Okay.
So why do you want to do Hopkins, Saumyta?
To rule out second primary in oro and hypopharynx.
What is difference between second primary tumor and okay, you tell me what is field cancerization?
Field cancerization is due to chronic exposure of a particular carcinogen in a full aerodigestive tract mucosa. It lead to the diffuse changes in the mucosa of the upper aerodigestive tract, like clonal expansion and clonal deposition of patchy changes in the oral mucal cavity. It's a field cancerization, which have a risk factor for the cancer for all upper aerodigestive tract.
Okay, basically it is due to exposure of the carcinogen to all the areas at risk. Okay, so they are likely to develop cancer. What is second primary tumor?
Second primary tumor.
What are the criteria to call second primary?
It should be away from more than 2 centimeter away from the primary lesion. It can be of different histology. It can be synchronous or metachronous, but if it is in the same time, it is synchronous. More than 6 months is metachronous.
More than 6 months, okay. And what is incidence of second primary tumor?
It's around 2 to 4% every year.
2 to 8%. 2 to 8%. Okay. Then what else is yeah? So what are the theories for field cancerization?
Seed and soil theory, ma'am.
Okay. Monoclonal. Anything clonal theory is there?
Clonal expansion. Clause of chromosome of 9q is there.
Monoclonal, polyclonal.
Monoclonal and polyclonal. Okay. So what is Warren-Gate criteria?
Warren-Gate criteria is for second primary, which says if a disease confined to the same region less than 2 years and same histology, so it is recurrent disease. If it is more than 2 years and it is away from the primary site, then it is after 2 years it's a second primary.
Okay. Do you know any other criteria other than Warren-Gate?
WHO criteria is also there, ma'am, in which more than 5 years they say second primary, less than 5 years is the recurrent, and more than 2 centimeter away from the lesion should be there from the primary site.
There's one host criteria, I think. Okay, but yeah, there is one more criteria, I think, but I'll just confirm and let you know. Okay, there's one more other than Warren-Gates. And Okay. Now you tell me what is the... Sorry?
SFT some criteria. Second trial.
It is solid tumor response criterion 2018.
There was one study, I think it's HO, but I'll just let you know in next class, okay? I forgot. Then you tell me what is the importance of induration here.
Induration is a palpatory finding, and it might be the lesion is not visible, but it's like thickening of the area around the ulcer, which is also a type which should be removed, or infiltration of tumor cells in the surrounding soft tissue. That it's called induration, ma'am.
So now your ulcer has got how much induration?
It's more than 5 mm from the original size of the ulcer.
So 0.5 centimeters. Okay. So, okay, fine. So whenever you're telling stage, no, so you should include this in T stage. Okay. It's not only the size of ulcer, it is degree of induration which accounts to addition of the T size. Okay. And then only you should tell final stage. Suppose here it is 3 centimeters. Suppose it was something like 3.7 and 0.5. So it changes the T stage. So that is important. So why are you concerned about tip of tongue and floor of mouth?
Floor of mouth, ma'am. Patient, if floor of mouth is involved, then our surgical plan will change. We need to do type 3B glossectomy. And tip of the tongue is an important factor for the speech. As I already told, it touch the heart palate to main proper vocabulary. So tip of the tongue is very important for functional aspect of the tongue.
Okay, so what is that syllable? Okay, what are the sounds which are important for this phonation using tongue movement?
Ta, ta, ta.
E.
E is
okay, monosyllable. Okay, then thatta dadana.
Ta, ta, ta.
Okay, so your tongue is touching there, right? You can test. Your tongue has to touch the palate to get that articulation. Okay. So fine. So how is it like important whether it has crossed midline or not? What is the importance of that?
If lesion crossing midline, then we should address the opposite neck nodes, and also the treatment plan is also will change, like subtotal glossectomy or near total glossectomy according to BOT. We will decide if.
Okay. Basically, when it is touching the midline, the opposite side has to be addressed. Okay, and the primary has to be resected more, like subtotal, whatever you told. Okay, so and anything, yeah, tell. Edentulous in tongue, it may not actually matter, but whenever you are telling in a dentulous patient, no, you just tell starting from an area opposite to which tooth, lower part, like starting from an area opposite to second incisor, extending up to an area opposite to second molar, like that. If in a dentulous patient, here it doesn't matter. Okay, and not everyone asks, but you should know about the taste sensations, where all the taste sensations are there: sour, sweet, okay, bitter, right? So where in sideways and bitter is the posterior most part, okay? And yeah, so neck notes. So in your case, no neck notes. If there are neck notes, what will you like to tell?
If there are neck nodes, then it is N1 or N2. If N1, it is stage 3. If N2, then it is stage 4. So survival of the patient depends on the clinical staging.
No, I'm not asking you the implications of neck nodes positivity. I'm asking how will you describe? Suppose there is a solitary lymph node in level 1B. Okay? Not here. Level 2 will take. Okay, tongue, na? So you tell me. So how will you describe it? What all you'll describe?
Okay. Single solitary lymph node I am palpating near the sub level 2. Near the
No, you can call it level 2, no problem. You are examining, right? So you tell me what all you'll see other than that. Same like breast only, right? What you will see in lymph nodes.
radiologically or clinically, ma'am?
Clinically only. I'm not asking radiologically.
Single solitary mobile lymph node in the
Single solitary is same.
Solitary mobile lymph node in the level 2, which is it's palpable, matlab it's significant, na?
Not necessarily. So you will tell about consistency, you will tell about what is the shape, right? We will tell about the level, whether it is tender or not tender. Even in your primary, I didn't see, you didn't mention about tenderness. Okay, that's important in tongue.
Tenderness and palpation I have mentioned.
Okay, tenderness. Okay, right. So that is in same in lymph node. Okay. So you tell it is T2 N0. Okay, fine. So we'll see the imaging, but first you tell me what is the incidence of occult lymph nodes on final, occult lymph nodes in N0 tongue.
20 to 30%, ma'am.
So does it depend on T stage or?
It depends on the T stage and site also. But for cavity, most of more than T2, if there, then its chances of occult metastasis for T2 is more than 20 to 30%.
Okay. So what are the most common lymph node levels that are involved in tongue?
Level 2, 3, and 4. If tip of the tongue, then it is bilateral supply. Then level 1 can also be there.
Okay. So I presume you know T staging, no? So I'm not asking T stage. Okay. So tell me what is the incidence of level 4 metastasis in the absence of level 1 to 3? I mean level 2 and 3.
And there are different studies which say different school of thoughts according to Byers et al.
So tell me something about N0 trial.
N0, Byers et al. And Mishra et al. Who talked about skip meds. That according to Byers et al., the stage 4 skip meds, they have included 3 and 4 together for CA tongue. That incidence is 15% around. But in other studies which done at the TMH and Mishra et al., which says only 2%, 1.2% around 1 to 2% chances of skip meds.
So Byers et al. Was the first study. Okay, he told about 16.5% are there, but his study has problem. So it was in presence of 2-3, so which was not documented. Okay, it was not isolated level 4 meds. Okay, later on this Gauri Pant et al. So they have told the metastasis to level 4 in absence of level 2 and 3. So it will be only about 3.4%. Okay, and level 2B it will be 2.3%. So this is Pant et al. Okay, so main studies are this only. And what about, do you know any studies for sentinel lymph nodes? What is the sentinel lymph nodes? What is status of sentinel lymph nodes in oral cavity cancers?
According to recent meta-analysis, which says that sentinel lymph node biopsy is comparable to elective lymph node dissection if done systematically with the dual dye technique.
What is problem with sentinel lymph node in oral cavity?
Problem is shine through phenomena of if a lesion in the floor of mouth, and second is radio at we have to do nuclear scan. For that we have to give radionucleotide a day before. So this
So it is cumbersome and it involves multiple steps. Okay, that is the problem with sentinel lymph nodes. And false negativity rate is high.
false
Okay.
rate is 14% according to the center.
Yes. Yes. Okay. Tell me two trials where they have done sentinel lymph node biopsy. Two prominent trials. Hashigawa. Yeah. Japanese trial. That is Hashigawa trial. And Central. That is. So these two have compared sentinel lymph node biopsy. So it involves multiple steps, as you told, and shine through effect is also a problem. So that's why sentinel lymph node has not been like as in breast. It is not done in oral cavity cancers. Okay.
False rate is also, ma'am.
False negative rate.
Every institute has to validate their technique in order to start this investigation in their center.
Yes. So, कम से कम 20 to 25 cases करना चाहिए, and the caseload should be high for them to do the sentinel lymph node biopsy. Okay, then only their results are validated. Okay. So yeah, so T2N0 clinically. So I suppose I'm not asking staging. Next candidate will ask staging. Okay. So tell me, what do you want to do? How do you want to proceed?
Ma'am, I would like to confirm my diagnosis and the stage the disease, and then proceed for treatment. For confirmation of diagnosis, I would like to do biopsy. For staging of disease, I would like to do MRI, CE, MRI, contrast enhanced MRI of face and neck. And after, since my clinical stage is T2 and 0, so I won't be doing. I will be doing chest X-ray for the metastatic work.
So, in all cases, do you want to do MRI?
We usually prefer for soft tissue tongue MRI if patient is affordable and it's feasible.
That's in your setting. What does NCCN say? It can be avoided in very early stages. Okay, not needed. Okay, your USG is as well sufficient because the incidence of metastasis is less than 0.5%. Okay, so where T1 lesions, it can be avoided. T1, T2, they say. Okay, so yeah. So now, so what biopsy you want to do? How do you want to do biopsy, and what biopsy you want to do?
I will like to, since this is ulcer-proliferative lesion, then I would like to spray over the LOX spray at the local region, and I will be taking punch biopsy from the most representative area so that I can necrotic tissue.
So you always start, I will explain the patient about the procedure. Okay. Then you will keep the tongue inside and take biopsy, or you want to?
I will ask the patient to protrude the tongue, and I will put a local spray and I will take biopsy after all aseptic precautions.
So generally you will hold the tongue with a gauze piece. Okay. The more they protrude, they will have little discomfort. Okay. So try to keep it inside and then turn it towards the opposite side. Means yours is on the left lateral, right lateral side. Okay. Then explain the patient about the procedure. Okay. Then what biopsy you took? Punch biopsy.
Punch biopsy. Or incision biopsy also we can take.
So anything? What is standard?
Incision biopsy is the standard because it can be done for all type of ulcers.
So generally they say wedge because you have to go through the. Why it is important? Why you should take wedge?
Because we are taking from the edge of the ulcer so that some normal mucosa should be there along with the.
Okay. Some people say, see, Tata people don't accept if you say edge wedge. Okay, but generally they accept edge wedge. Okay, but you have to take wedge. Why do you take wedge? That is my question.
So that basement membrane should come along with the breach of the basement membranes is important to understand now to differentiate it.
Okay. Now I will ask you a question. Okay, what is depth of invasion? What is tumor thickness?
Depth of invasion is the pathological finding which is measured only by the. We draw one horizontal line from the basement membrane and one vertical line from the tip of the ulcer. So this is the depth of invasion. And tumor thickness we can palpate, but it's not always coincide with the DOI.
So you should know this tumor thickness and depth of invasion definition. Okay. So okay, I will tell you definition. You tell what it is. Okay. It is the distance between the most prominent part of the ulcer till the basement membrane. So what is this?
It is thickness.
Yeah. So in exophytic lesions, what happens?
In
Which is more?
exophytic lesion, thickness is more than DOI. DOI is more than thickness.
Think and tell. Don't get confused. Okay, what is DOI? What is DOI?
Horizontal line from the basement membrane and plumb line from the tip of the ulcer to the base of the ulcer.
It is between normal and ulcer mucosa. Okay, till the basement membrane. Okay, now you tell. Suppose it is exophytic lesion. So what will be more?
Exophytic and thickness will be more.
One is like a mountain you imagine, Ray. Okay, mountain on the land, and one is deep below. Okay, you think floor of earth. Okay, so from the peak of the mountain till the floor of the earth, so is the tumor thickness. Okay, from the normal surface of the earth and mountain till the floor of the earth is the DOI. So now you tell, suppose it's exophytic. So it is like a mountain. So what is more?
Thickness is more than DOI.
What is in endophytic lesions?
And the endophytic lesion thickness is less than DOI.
Okay.
And DOI is more.
So what is depth of invasion significance and who told about it? What is the study saying? Importance of depth of invasion.
Depth of invasion given by Abrahimi et al. He given the concept in 2014. According to his study, this concept adapted by AJCC that less than 5 to 10, more than 10. And later, same author studied in 2018, 19 for its correlation with the adjuvant treatment. According to him, if DOI is more than 10 mm, then patient can get benefit for adjuvant RT.
Okay, in your clinical practice, you take it cutoff is
10 mm.
so anything more than 4 mm is risk, but clinical practice will take 6 mm. Okay, but if in absence of other risk factors, you can avoid RT. That is what about is arrest trial. Okay, so in only with relation to depth of invasion, you need not consider for adjuvant RT because you should always reserve one modality of treatment for any future recurrences. So that is the concept why of the arrest trial, whatever they're doing. Okay, so yeah, so what was I asking? So depth of invasion we have done. Do you want to do frozen section? What is your idea about frozen section in oral cavity cancers? And what is the study?
According to Chaturvedi sir at Chaturvedi at
No.
Chakravarti.
Something starting with M.
I don't remember.
So read and tell. Okay. So as per him, frozen section.
Mustafa
The
Bulbul. According to Mustafa Bulbul.
Tell what you told.
According to that study, if we are doing primary resection, R0 in the first attempt and with a proper margin, then no benefit of doing if close margin is there in the first resection, there is no benefit of re-resection for after frozen section.
Okay, you are telling about specimen derived margins and patient derived margin.
Yes.
My question is about frozen section. So do you do frozen section and how far is it reliable?
The frozen section is not that cost effective and facility if not available if a surgeon is taking near about 1 centimeter margin. So after formalin fixation more than 30% shrinkage. So in order to get a clear margin that is 5 mm, a surgeon should take 7 mm margin near to get same 5 mm margin. So if frozen facility is not available and surgeon is taking more than 1 centimeter gross margin, then chances are very less to get close margin.
Okay. Next class, you will tell me what is sensitivity, what is false negative rate, okay, with frozen section. Okay. So now you told about the margins. So what is positive margin? What is close margin? What is negative margin?
More than 5 mm is negative margin and 2 to 5 mm is the close margin and less than 1 mm is the involved margin.
Okay. So whose studies were there for this margins? Tell me only 2 studies which were like actually.
Anderson et al. Is a meta-analysis, ma'am.
Who told like you can take 2 mm also? And somebody told that 2 mm in 2 mm also there is 12% incidence of occult lymph node metastasis in 2 mm like this one also.
N0 neck, Anil D. Cruz sir told 2 mm also leads to occult margin. So
okay. First one was Jatin Shah et al. Okay.
Jatin Shah.
So his was proposed as 5 mm. Okay. Initially that was 7 mm. Okay. But 7 mm is too much. 5 mm was standardized, which was from Shaw et al. Then 2 mm also had, there were many studies saying that in 2 mm and all you can avoid. But Anil D. Cruz told that there will be at least, even 2 mm, this one, there will be incidence of 12%, 12.5% metastasis. So, okay. Next, yeah. So, N0. Do you know the percentage of contralateral metastasis, ipsilateral level 2, 3, 4 for respective two stages?
No, ma'am. I have to read this.
What is the incidence of contralateral metastasis in a lesion, very low lateralized lesion, and what is the incidence of contralateral metastasis in a lesion approaching midline? Okay, both you have to know. Okay, there's a table in data. Okay. And there is what is the incidence of metastasis in this T site with level 2, level 3. Okay. T1 में कितना होता है, T2 में कितना होता है. Okay, level 4 I told you already, and level 5. So what is the instance of metastasis if level 2 and 3 are positive to level 5? So when will you do level 5, by the way?
Ma'am, when level 2B is positive, then we are addressing level 5. And
Okay.
when 3 is positive, we are addressing level 4.
So, so what is the most of the types? If you are there were any studies that have compared SOND to SOND, extended supraomoid to supraomoid?
No, I have to read that, ma'am. No.
Yeah. So there was one Chinese study, Wang et al. Okay. So they have compared SOND to SOHND. So they have told that in early lesions, it doesn't make any difference, and it adds to little morbidity. So even SOHND is almost equivalent to SOHND. But it was criticism was that standardization of the procedure. So that was okay. So next, So can you tell me something about Anil Dikru's study? What is the tell me something about Anil Dikru's study, N0 trial, basically.
N0 trial has compared with elective lymph node dissection versus therapeutic dissection.
So what is incidence of disease-free survival and recurrence?
Some percentage I am not remembering.
This percentage you should remember. 1 in 8, 1 in 4, 12.5 and 23. Okay.
12.
So 12.5 and 23. Okay. So we will discuss all. See, these percentages are very important in oral cavity cancers. Some trials are there, no? Some trials are very like standard trials. They expect you to know. Okay. One of such trials are N0 trial, SLNB trial, CEN trial, Hasegawa et al., Japanese trial. Okay. Then this RTO, what is the trial for depth of invasion, ICAR study, that is Ibrahim et al. You already told that. And that is ICAR study. And next is, they'll expect you to know what is Cooper et al. Study. So these are all some studies which you should know. What is indication for radiation, chemoradiation, why chemoradiation is preferred, soft indicators, all these are important. Okay? These are standard questions. Okay? So, so now you did edge-wedge biopsy. Okay, you have told me about the biopsy and all. So what do you want to see in the biopsy report?
Biopsy, LVI, PNI, grade.
I'm not asking in histopathology, primary biopsy report. So you will see what is the
type of histology, squamous cell or any other verrucous.
Okay. So what is problem with verrucous?
Verrucous is the well differentiated is a variant of well differentiated squamous cell carcinoma. So it's a locally aggressive and not metastasized to the lymph nodes.
Okay. You did a biopsy, Saumyta. In that, one came as high-grade dysplasia. The possibility of invasion could not be ruled out. Okay? You did first time. Second time, Same. High-grade dysplasia, possibility of invasion cannot be ruled out. You repeated the biopsy.
Yeah.
What do you have to do?
Then I would like to do excisional biopsy with the negative consent, or I can proceed with like a carcinoma. Explaining to the patient might be the chances of negative histopathology as a cancer, but high risk disease. Then it should be excised so that we can see the risk factor or possibility of cancer.
Okay. And what will you tell about addressing lymph nodes?
We will, if frozen section facility is available as in our center, we are usually sending for a confirmation of diagnosis for the frozen section. In frozen section, it's coming positive. Then we are addressing lymph node accordingly. But if in case it's not available also, then after taking this negative consent, we are addressing lymph node for high risk patient. That is level 1, 2, 3.
Yeah. In tongue, even elective neck dissection will do. Okay. Most of them you will not get in depth. So final histopathology will be positive. So you're not wrong. As you told, you will explain the patient and do a neck dissection. Okay. So fine. So what all you will see? Your histopathology report has come. You did a biopsy. So you did, one is invasive squamous cell carcinoma. Then what else you want to know?
Invasive squamous cell carcinoma is the main thing, ma'am. If it's come, then we will plan our treatment.
नहीं रे अभी तो बायोप्सी भेजी बायोप्सी रिपोर्ट क्या क्या है क्या
well differentiated, moderately differentiated, they will mention.
What is the grading?
Borders grading we are using.
So what is it based on?
It's based on the undifferentiated cells. Well differentiated, less than 25% undifferentiated cells. Moderately differentiated, then 25 to 50% undifferentiated. Undifferentiated, more than 75% cells are undifferentiated.
Okay. Anything related to keratin pulse?
Keratin pulse are present in well differentiated carcinoma.
What is its grading? Name? B से शुरू होता है. Anyone else? ब्रॉडर्स का नाम सुना है?
ब्रॉडर्स तो मैंने बताया.
हाँ, Broadus. That is, I asked name only. Okay. So, okay. Then can you, sometimes you will get DOI also. Okay. And they will comment on LVI also. Okay, sometimes. Not always. In a good report. Okay. Next, you have confirmed your diagnosis. It is moderately differentiated squamous cell carcinoma. Okay. No LVI to the extent visualized. Okay. So, yeah. Next, what do you want to do?
Sir, after clinico-radiological confirmation of the stage, I will plan surgery of the patient.
Okay, you will explain patient. What you will
explain regarding the disease of the patient, and for this disease, what treatment options available, and
अभी तेरी ही patient मैं हूँ. Explain.
So for you, it's like squamous cell carcinoma. Tongue patient is having squamous cell carcinoma, and for this surgery is the best treatment, and along with the neck dissection, so that for whatever we are removing in the resection, we will like to reconstruct, and the best option of reconstruction for this patient will be free arm radial artery forearm flap. This option will give you good mobility, but if financial constraints and facility of microvascular surgeon is not available, then I would like to do local regional flaps, pectoralis major, myocutaneous flap, or trip MFF also. मतलब fascia only we can take along with the muscle, avoiding the skin. This is also one type of flap. So we'll explain, and there can be a chances of post-op, intra-op, post-op complications like hematoma, serous fluid, guile leak. But if you are taking surgery at this time, your survival will be uh, around 70%.
Okay. Something very important you forgot to tell. I am concerned about my speech. Will you explain?
Stage 2.
Will
Stage
Will
2.
my speech change, or will there be any slurring or anything?
Speech.
Hmm.
Speech, in starting phase there might be some problem. After proper speech therapy, you will be able to speak what cognizable speech. You will able to speak after 1 month of operation.
So what about my swallowing? I'll be able to take orally immediately after you operate?
You have to take for few days, like 15 for oral cavity. Tongue lesion, it's like up to 1 week you cannot take anything. You will be giving all the food by the ice tube. After that we will start liquid diet, and you can have whatever you want after 15 days of the surgery.
So whoever is presenting next, I will ask about phases of speech and phases of swallowing. Okay, they read and come. Okay. Fine. So you'll give RT feeds. Okay. So whenever you explain patient, they don't know whether you are putting PMMC or free flap. Okay. When you are asked, like sometimes examiner says, I am your patient, you explain to me. Then you should tell there are options available. Okay. Surgery and versus radiation. So the best option is surgery, which will involve dissection of the primary, okay, addressing the lymph nodes, as well as the reconstruction of the defect. Okay, dissection of the primary will involve this much removal of your tongue, which will have its effect on your functional things. Okay, what is the effect due to that removal of the tongue? So what am I going to do with, what are the possible intra-op complications? If there is any need, we have to take you up again for surgery. Okay. The raw area can be closed by 3 means. One is the primary closure. Then sometimes patient comes to you like they're not affordable at all. Okay. Okay. So that will depend upon extent of your resection. So can you tell me one study which told about how much extent of resection it needs a cover? Okay, but how much extent, what extent will be closed primarily? What is that study?
Less than study, I don't know. Less than 30 primary closure can be done. 30 to 50 we can go for local regional flap. More than 50% for sure we should go for free flap, ALT, or radial artery forearm flap.
So anything less than 30% primary closure can be done. More than 30% you need a cover, be it a free flap or be it a pedicle flap. Okay. So Muhammad Ansari. Okay.
Answering classification only type 3A, 3B.
Yeah. Can you tell me what is type 1, 2A?
Type 1 is mucosectomy. Type 2 is partial loss.
What mucosectomy?
What mucosectomy?
What is mucosectomy? Up to what extent you will remove? Only the mucosa. Okay.
Mucosa, submucosa.
Where you see?
Submucosal sleeve, like At the submucosa, SM1 level, we will try to dissect.
Only the mucosa is removed. So in others, you will see the extent of when up to you will visualize the intrinsic muscles. Okay, and then it also depends upon how much exterior. Like, okay, you tell me that types first, then I'll tell.
Type 1 is mucosectomy, type 2 is partial glossectomy, type 3 hemiglossectomy, 3.
So what is partial glossectomy?
Huh?
What is partial glossectomy?
Partial glossectomy is less than 50% of the tongue if we are removing. Hemiglossectomy, full from BOT to anterior tip of the tongue we are removing, then it is hemiglossectomy. If less than that we are removing, then it is partial glossectomy.
So there is a description in that study. You read carefully, okay, up to the extent of visualization of the intrinsic muscles, what are preserved, what are the nerve bundles which are preserved, one half of the tongue, okay, base of tongue involvement, subtotal.
Compartment includes full neurovascular bundle 3B, from which we are removing from mitohyoid, full genioglossus muscle along with neurovascular bundle with full let one side of the tongue. And near total glossectomy is type 4, in which one side of BOT should be preserved, and उससे पहले 4A is subtotal glossectomy. In bilateral BOT is preserved. 4B is near total glossectomy, in which one side of BOT is preserved, rest all tongue we are removing, and 5 is total glossectomy.
Yeah, so anterior glossectomy is 4A. Okay, then okay, what is the glossectomy you will do in this case? Your case?
I will like to do type 3A glossectomy for this patient because it's close to the lingual nerve of this area.
So you want to do 3A?
Because flora of mouth is free. Flora of mouth
is
free, ma'am.
Hmm.
That's why I like to do type 3A. Flora of mouth is involved. I will like to do compartment for this patient.
Why not 2? Partial glossectomy?
Partial glossectomy because in midline it is less than 1 centimeter from the frenulum. So for this type of disease, I have to remove from the midline.
It's 1 centimeter, right? It looks little more only there. Okay, fine. Grossly, you want to take 1 centimeter's margin approaching the frenulum. I feel partial will do, but maybe you have examined, so you are more this one. Fine. So you want to do reconstruction in this case, right?
Yes, ma'am.
Either you will do a PMMC or you will do a free flow. So if you do a PMMC, what is the pedicle it is based on?
Thoracoacromial artery.
Okay. If you do a okay, PMMC में भी है ना, तो there are random flap, most of it random if you take. So you have to, it is based on that, what is it? Chimeric vessels. Okay. So fine. PMMC का harvesting का भी पूछ सकते हैं. So we'll discuss reconstruction in detail in further classes. Okay. Today we'll go till your management. Then we'll whoever is presenting next, we'll discuss about phases of swallowing, speech, the functional things, and reconstruction more detail. Then fine. Then free flap, what do you want to use?
Radial artery forearm flap. No?
Free
Because
radial artery flap. Okay.
free radial artery forearm flap.
Why? And what is it based on?
Based on radial artery and cephalic vein.
Okay. So where do you anastomose?
From
I mean-
facial artery in the neck, and we usually use two veiny committents of the branches of the vein. One with the external jugular veins, another with the internal jugular vein.
Okay, fine. So, okay, we'll discuss in detail next class, okay, about that. And if it is anything dependent on ALT, can you use ALT, or what is the problem with ALT?
For this patient, I won't be using ALT because I'm using only removing half.
No, not this patient. In general, what is the use of ALT?
If near
Will you use ALT like that?
total
Or
glossary,
what is problem with ALT?
because it's very bulky flap, so it's lead to oral swelling and decrease mobility. But in due course of time, after RT and all, this shrinkage the tumor is there and fibrosis, so it gives better result if the bulk of the flap is required.
Yeah, if it is more amount of tongue resection, ALT is preferable. Okay, not in your case, but when you do a subtotal or near total, so ALT is more preferred. Okay, the problem with ALT is, as you told, it is very bulky, so it will interfere with the respiration. Okay, because of the bulk. And what is ALT based on?
Descending branch of lateral circumflex femoral artery.
Okay. And anything else? Local flaps, if it is a small lesion per tongue.
For small lesion, we can do island nasolabial is the one of the good option because it also gives good mobility.
Nasolabial.
Island nasolabial, ma'am. In this whole facial vein and facial artery, whole length we are preserving, and we are taking a patch of skin, muscle, and subacute, and then we are doing tunneling in the submandibular region, and so this big length of the facial artery and facial vein, it gives good mobility. It's work like a free flap only, because in free flap also we are doing analysis with the facial vein and facial artery now.
So is the mobility dependent on your flap reconstruction, or what is it dependent on?
Actually, there should be a free the tongue flow.
It is dependent on native tongue. Okay. The residual tongue, it is not dependent on your flap. Whatever is moving is because of what is the residual amount of tongue you have left. It is not because of the flap. Okay. So that whatever
we are taking stitches with the FOM and all ना, तो उसमें मोबिलिटी टंग की रिस्ट्रिक्ट हो जाती है, एंड पीएमएमसी का डायरेक्शन इज टुवर्ड्स द ग्रेविटी, so it gives a pull to the tongue, so towards anti-gravity movement is little compromised with the regional PMMC flap.
Yeah, but whatever mobility you're getting, it is because of the
remaining
residual tongue, not the flap. Okay, that you should remember. Okay, so are these sensate flaps or not sensate flaps?
Normally, we are cutting the nerve. Normally, we are cutting the nerve.
And not sensate. Okay. So Fine. So that's about. Okay, tell me something about neck dissection. So this is about the primary reconstruction. Tell me something about the neck dissection. What is MRND? What is SOHND? When will you do?
If lymph node is positive, then terminology has been changed to comprehensive neck dissection, and
Okay.
that is level 1 to level 5. And whatever structures, if we are removing, we can.
So now the terminology has been everything selective, comprehensive, everything. Nothing is there. Whatever lymph nodes you are removing, that you have to mention. Okay. So there is no new terminology. Will only include what lymph nodes you are removing. That has to be mentioned. There's nothing like SOHND, SHOND, or MRND. Okay.
And for neck, we will have selective node dissection, SND, and in which bracket we have to mention what level we are removing. For this lesion, as patient is CA tongue, I would like to do address level 1 to level 4 lymph nodes. And if in case I am sending it for the frozen section, it turns out to be positive or at level 2, then I would like to do level 5 also.
Okay. So tell me what is difference between this selective and radical net dissections.
Selective lymph node dissection, ma'am, primary draining area of the lymph node should be addressed. But in comprehensive or neck dissection or radical neck dissection, in radical neck dissection, we are removing one structure like sternocleidomastoid, spinacerin, or jugular vein. If any extra structure we are removing in spite of 1 to 5 nodes, we are saying it's radical neck dissection.
Fine. So, what is MRND? I mean, it's old terminology, but some old examiners may ask. What's MRND type 1, type 2, type 3?
MRND type 3, 1 and 2, it depends on the how many structures, that is spinacery nerve is the one of the important structure which we are trying to preserve. If 3 structure, MRND 3 means all 3 structures are preserved. MRND 2, 2 structures we are one structure we are compromising, and all 3 are we are removing.
So nerve, nerve vein, and nerve vein muscle. Okay, clean. Okay. We will discuss about neck dissection in detail in further classes.
So from neck dissection, level 1 to 3, ESTD extended supra when we are adding 4 to the level 1, 2, and 3. These 2 points you asked.
Okay. So I will ask about the boundaries and all to the next person. Okay. So 3 already I told, whatever I'll ask. Next person, whoever is presenting, I'll ask these things. Okay. Next, so you want to do ESOHND, right? With left ESOHND with preferably free flap if patient is affordable. Okay. So, right. So next, what next? Yeah, you describe this. They have done MRI. So you tell.
So according to this, ma'am, the left lateral border of the lesion, which is going to near the...
No. Whenever you are describing image, tell what image, what cuts. Okay.
This is the T1 image of this coronal section, in which I am able to see ventral aspect of the tongue, in which there is an enhancing lesion in the left lateral border of the tongue, which is near the lingual nerve, or what I should, that there is no separate plane in which I can see the lingual nerve opening, ma'am.
Okay, you see, you have a cursor with you.
Mm-hmm. Not cursor. I'm not having cursor.
Next time, no, like yesterday's images also, like we couldn't explain. Whoever is presenting, you just put so that you can point out something.
Oh, pen मेरे पास.
So what are the things that you look for in MRI? First, start. Why do you want to do MRI? I will tell
for
this
the base of the tongue. I want to look for the proper margin vallecula and is a DOI and region crossing midline or and for neck if neck nodes are present or not.
So you can sorry, I was not able to get.
Depth of invasion, floor of mouth involvement, vallecula involvement, extrinsic muscle involvement, and lesion crossing midline or not.
Oh, fine. So, can you tell me, like, suppose, okay, which sequence of MRI is the best to look for primary?
T1.
So, what are the sequences you know?
T1, T2, and FATS, diffusion weighted or stir image.
Which sequence is better to know the contour?
For anatomy, T1 is better, ma'am. For pathology, T2 is better.
Okay, but of all this which you have told, which sequence is better?
For tongue, STIR is better.
Yeah. What is STR?
Tau, full form.
Inversion recovery. Okay. So, fine. So, what you want to see? Neurovascular bundle is involved. So, what you are saying, lingual nerve and all, no? So, what are the signs of neurovascular bundle involvement on MRI?
Widening of foramina, if some foramina is there, and
There are 5 points. Okay. First is enhancement. Okay. Second is loss of fat planes, the neurovascular bundle. And third is foraminal widening. Okay, there is in acute cases like something means recent involvement of neurovascular bundle, there will be muscle edema. Okay, and there will be atrophy of that particular muscle because of denervation. So these are the 5 things that neurovascular bundle is involved. You will see on MRI. Okay. So. Okay, there are some sections, okay, so which are specific for, suppose, sagittal section. What muscle you will see? On coronal section, what muscle is well seen? Can you tell me?
in this muscle we can see जीनियोक्लॉसिस इसमें नहीं दिखती जीनियोक्लॉसिस इसमें दिखती है in this muscle we can in this sagittal plane we can see genioglossus in this palatoglossus I will read
seen in all the images, okay, all the cuts. Hyoglossus is best seen in sagittal cuts, okay, and mylohyoid is seen in coronal sections, okay, and
yes able to see in coronal, okay,
coronal, yeah. Genial tubercles are better seen in sagittal sections, okay, and this one you can comment on if there is. This is yours is anterior 2/3, but if it is posterior, you'll know about like tonsil involvement, tonsillolingual sulcus. You can see. Okay, so
this plane, sagittal plane.
Yeah. So, right. So can you tell me something about ओके पोस्टीरियर टंग में डिस्कस करेंगे वो हायोइड और क्या है करके यू टेल मी समथिंग इन्वेशन
Yes, ma'am. Not able to hear.
PNI. PNI. I'm asking about PNI. What is importance of PNI?
PNI is an independent prognostic factor, which for which we can give adjuvant radiation for the patient. It is named unnamed nerve involved near the any soft tissue structure, which our primary structure. It can be intratumoral or extratumoral, and
So it is less than 2 centimeters, more than 2 centimeters, named nerves, large nerves, small nerves. Okay, contiguous, non-contiguous. Okay. So these are there's a paper no based on PNA. So it's most likely to be included in the further classifications. So this is important prognostic factor. Okay. So and what in which section will you see the better of neurovascular bundle involvement? Which section?
you, ma'am.
Coronal section, correct. So, so you mainly you will see midline crossing, neurovascular bundle involvement. Okay, and what is neck nodes that like you would like to see?
I would like to see ipsilateral 2, 3, 4 level of lymph nodes.
Okay. So when we discuss the borders and all, like that time only we'll discuss what are the boundaries in MRI also. Okay. So next time. And what is compartmental resection?
Compartment resection, we are removing ipsilateral along with all neurovascular bundle along with the musculature of that draining area, so that transit or in transit nets can be taken with the n mass.
So entire neurovascular bundle and whatever the possible from origin to insertion, all the musculature is cut. Okay, means the possible route of spread. Okay, lymph nodal tract. The possible entire margins from origin to insertion are cut. Okay, what was this? Who gave this concept of compartmental section?
Calabrese et al.
What was the problem? What he told and what was the follow-up study told? Like, what is the use of compartmental resection? Is it actually worth it?
I have to read, ma'am. I don't know.
There is this Calabrese et al. Has proposed that whenever we remove this possible lymph nodal tract from origin to insertion, then there will be less amount of recurrences. Okay, so but Italy, there is a study from Italy which they have done on follow up. They have actually told that they have not agreed with the Calabrese et al. Study. They told that it is overtreating. Okay, so we will get the locoregional and there is increased morbidity and functional derailment because of this compartmental resection, and which can be the local recurrences are almost equivalent to when we address with the glossectomy. So there is no much use of compartmental resection. It was told by a study from Italy. Okay, and follow. So, and many people, they will not fare well. You do compartmental resection because of the morbidity and all, and there is no difference in overall survival, whether you are doing a compartmental resection or a whatever glossectomy with primary repair and reconstruction. So morbidity is more, and there is no change in distant metastasis. So that is what Italy study from Italy has told. Okay, so what is suppose flora of mouth you are telling, right? Suppose flora of mouth is involved. So what are your approaches to resection?
We can go by visor incision also, intraoral also we can go. We should not give any separate incision. Along with 1B, we are removing.
problem with this floor of mouth? Why are you so much concerned about floor of mouth?
Because it will be leading to connection between oral cavity and which is orocutaneous fistula, and because floor
No.
of mouth is a barrier between the oral cavity and the neck, so saliva should not.
Is that your concern or something else? What is function of floor of mouth muscles?
Floor of mouth.
So they also help in phases of swallowing. Okay, so that's why the importance of floor of mouth muscles. So their approaches, they can intraorally, if it is good, you can go through that. Visor approach you can do pull through, you can do mandibulotomy approach. Okay, so what was the study which told about pull through and mandibulotomy? And this you told about types of glossectomy, no? Whether they have done through mandibulotomy or what was the approach they have taken?
In our what they have taken, I don't know. But in our setting, we don't do mandibulectomy.
Yeah, they told through mandibulotomy. Okay, in pull through and mandibulotomy is less morbid. Okay, but you need a hardware. Whenever you do mandibulotomy, you need a hardware, no? So that is the problem with it. It's less morbid and more acceptable. But pull through is more morbid. Okay, and the floor of mouth is disrupted through that. So long-term systematic reviews have told no difference in outcomes. Okay, you can use a midline approach, you can use a visor approach. So all these are things to approach the lesions which are extending to that. Okay, so what about what you told me? PMMC is one thoracoacromial, no? Anything else that PMMC is supplied by?
PMMC.
Pedicle is thoracoacromial. Pectoral branch of thoracoacromial.
Lateral pectoral is also there, but lateral pectoral we usually cut in order
lateral.
Lateral pectoral is crossing.
No. They're paramammary perforators and lateral thoracic vessels, okay, which are the additional branches. Okay. Then what is you can actually ALT bulky में जब होता है ना, there is something called thin leg ALT. Okay. So where this vastus is not taken. So this can be used when you feel the bulky flap is there rather than what is required. Next, posterior tongue ka hypomandibular suspension, and we'll discuss later. Next case we'll discuss. Okay, that
will take them advanced.
Yeah, we'll take in that. So now, your report will come. Okay. So we did reconstruction, repair, everything. So you told me Riles tube. What else you'll see? How do you monitor the flap?
We usually 2-hourly we take one needle scratching over the flap to see the flow of the flap.
So now 2 scenarios here. Okay, 3 scenarios. One is bright red blood is coming. You are happy with that? Or one is dark red blood.
Bright red.
Slowly it is, or it is coming briefly, and blood is not coming. So which scenario you are happy?
Less than 5 seconds. If it's coming bright red, I am happy. If more than 10 seconds, it's delayed. But it's bright red. Then also it's like okay. But more than 10 seconds or delayed or it's dark or not coming, I'm not okay. If dark blood is coming, then it's congested. Then I have to see for the venous congestion is there. So I have to relook.
So it should come slow, steady, and on the reddish tinge. Okay, that is thing. So first 48 hours. Okay, we will monitor every 2 hours. Then every 6 hours. Okay. Then later on, you will just see once a day like that. Fine. There is one next class, bias or diastatic will study. I'll also ask about complications of neck dissection and all. And now you tell me your report has come. Okay. 3 cross 2.5 centimeters lesion on the left lateral border of the tongue. 3 cross 2.5 cross 1 centimeter lesion, left lateral border of the tongue, with a grade moderately differentiated squamous cell carcinoma, with no LVI, no PNI. Depth of invasion is 6 mm. Okay, and yeah, nodes में से 0 of 12 nodes. Okay, dissected are positive. So and what WPOI is 3. So now you tell me what are your risk factors in this histopathology report.
Minimum 15 nodes should be removed for selective lymph node dissection.
What is in MRND?
18.
Okay. So what about this one? What? Yeah. So what are your risk factors in this?
And more than 5 mm DOI, matlab T2, it's T2N0. Worst pattern of invasion is 3 is not that significant. LVIPNI is negative.
So nowadays they're mentioning about this budding also, tumor budding. Okay. And they're also mentioning about this.
Tumor infiltrating lymphocytes.
So you're happy if it is still there or not happy?
If tumor infiltrating lymphocytes are present, then it's good for the patient.
Okay.
If it is absent, then it's a bad prognostic factor.
Yeah, because your immunity is not working. That's it. Okay. So now, yeah. So no PNA, no LV. Depth of invasion is the only risk factor in this. Lymph nodes are adequately removed for ESHOND. I told 12 last. Okay. Okay. 15. We'll take 15. Okay. So, so what do you want to do? And what studies supporting that? Whatever you are telling, treatment for the treatment.
For Bernier and Cooper et al., these are the 2 studies which have studied the prognostic factor. So all these which came to our histopathology reports are the not an indicator for giving adjuvant RT. So for this type of patient, we can observe.
Okay. So how frequently you want to follow
up? Every 2 monthly for 1 year and 3 monthly for second year. Usually for observation patient, we decrease the duration. Otherwise, for regular follow-up, every 3 monthly for 2 years. But for close observation, we are 2 monthly we are doing till 2 years, because most of the chances of recurrence within 2 years. Then 6 monthly for next 3 up to 5 years, then yearly.
Okay. When do you want to do imaging? Is there any role of imaging?
We usually do in imaging until patient is having any symptom which cannot be correlated clinically. Otherwise, the clinical examination itself is sufficient.
Okay. For high risk lesions, means this T3, T4, annual imaging you can, okay, or in case of any suspicion. Otherwise, not needed. Okay. Clinical examination itself is enough. Neck को monitor करने के लिए
Neck clinical examination we are doing until and unless we are having any doubt about. But USG neck can be done if. But in our study we are not any.
What was the study which told about comparison of USG, MRI, PET? PET का क्या role है?
For any large node at infracricoid region or level 4, then we should do PET scan to see the mediastinal lymph node and mediastinal staging. Otherwise, NCCT chest is sufficient for most of the patients.
Okay, fine. So, can you tell me some study which has compared the sensitivity and specificity of ultrasound, PET, and MRI?
नहीं मैं आपको
Tell me next time, okay? So, in MRI, okay, we discussed already that stir imaging is the ideal. In axial section, you will see the size, extent, hyoglossus, and depth of invasion. Okay. And in coronal sections, you will see the myelohasling, neurovascular bundle, okay, floor of mouth involved better. And sagittal sections, you will see the, it is more for the hard palate and thyroid, how in relation to sleep, okay. So, okay, what is posterior mode tongues? We discussed about, you told me already about lingual chorda tympani nerve, okay, which is at the pinna, okay, and glossopharyngeal, that is posterior most tongue, tympanic in the middle ear. So, what is the nerve that supplies posterior most part of the tongue? Correct.
Vagus.
Which branch? Or Arnold branch of vagus. Okay. So, yeah. So you told me that shrinkage of the tumor, right? Correct. So for which substance it is more, like most of
mucosa, ma'am. Buccal cap. More than 30% after formalin.
33%. So in tongue, I think it is around 22 to 27, something between that. Okay. So then what else? We discovered indications for the radiation, indications for chemoradiation.
For chemoradiation, that is extranodal capsular extension or extranodal extension is one of the same thing, and positive margins are the two definitive indications.
Yes.
And there are some soft indications like more than 6 multiple lymph node positive or large lymph nodal mass. Then can be considered with multiple risk factors in the same patient. Then also with one of the soft indicators for the external extension for adjuvant CTRT. But T3, T4, node positive, and LVI, PNI, and DOI more than 10 mm was pattern of invasion 5. All these are the hard indication for adjuvant radiation.
Okay. So, what are the imaging findings of a positive nodal improvement?
Loss of fatty hilum, necrosis in the center, and attachment with the peripheral structures like muscle. These are the findings of or more than 1 centimeter hypoechoic
You start always with size, shape, rounded nodes with short axis diameter more than 1 centimeter, with loss of fatty hilum, with central necrosis, low ADC on diffusion weighted imaging, and obliteration of the fat planes with capsular breach. Okay, this is how you can tell involved node. Okay, then okay, suppose PRT, RT you discussed, follow-up we discussed. I think we'll stop here now. There will be no end to oral cavity. We'll discuss it.
Yes, ma'am. When you will be free next? Because हम लोग 3 day में 2 ही दिन कर पाए इसलिए.
We did okay. Next week only, re.
Okay. Tuesday and
Tuesday. We have not got next week list as of now, but I will try to take Tuesday or Friday like this, and
Tuesday.
if possible, Saturday I'll take. Okay, next week, not this week. Okay.
Okay. Thank you,
madam.
Yeah.
I know, ma'am, lot of improvement required, but nobody was ready to present, so I have presented.
Well, don't worry, okay? All of you are doing well. Don't keep presenting that. And you did well. Last time, not Avneet also did well. Okay? All of you are, you keep, but keep presenting. Keep presenting. And breast present karo koi. It's very important. My exam goes without breast.
Present, I am posted in head and neck, so I will try to cover thyroid and one more oral cavity case.
But someone
I
next
think
week
is also maxilla.
I was thinking to present a buccal mucosa.
I'll present a breast next week.
who is presenting?
I'll present Ishita.
I'll present buccal mucosa.
But advanced breast, okay?
Okay, ma'am.
Generally, they don't ask about metastasis, but we will cover in early and locally advanced only little points about metastatic, okay? But one of you present, again, see, every week should contain one breast, one mucosa. Breasts are not like